Hello, everyone. My name is Caitlin Bavis-Lasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our educational webinar hosted by Lymphoma Canada on mantle cell lymphoma. We appreciate those of you able to join us live today to learn more about the disease-specific biology of mantle cell lymphoma, and we'll further examine the current Canadian treatment options available. This presentation will also highlight treatments coming to Canada and the research and results behind new therapies and clinical trials. Before I go ahead and introduce today's speaker, I'd like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or microphone. If you do have a question, please save it for the non-Hodgkin lymphoma question and answer session following this breakout presentation. You can then ask your questions to the presenters live. I would now like to go ahead and introduce and welcome our speaker today, Dr. Diego Villa. Dr. Villa is a clinical associate professor at the University of British Columbia and a medical oncologist at the BC Cancer Agency in Vancouver. He is involved in the care of patients with lymphoid malignancies, and his research interests include the management of mantle cell lymphoma, and he is further a local principal investigator for various international lymphoma clinical trials open in Vancouver. We thank you very much for joining us today to speak on this lymphoma subtype. I would now like to turn over the presentation to you, Dr. Villa. Thank you.
Thank you very much, Caitlin, and welcome everyone to this presentation. So my name is Diego Villa, and I have a special passion for mantle cell lymphoma, so hopefully I can share that with all of you today. This is the outline of today's talk. We'll spend about a third of the presentation going over some background and some biology of mantle cell lymphoma. We'll then talk about frontline therapy in young and older patients, and then we'll spend the rest of the time discussing therapy for relapse refractory mantle cell lymphoma, as well as some of the emerging treatments for this disease. Before we start, it's important to get some terminology down, because I'll be discussing response rates and survival analysis several times. So I think it's important for everyone to speak the same language. So what I'm showing on this slide is a scan of a person who has a large mass in their chest. You can see there's a large mass right in front of the heart. Now this patient's going to have some treatment, and different things could happen. That mass could shrink very significantly to the point you can barely see it, and we generally call that a complete response. Or that mass could shrink by at least 20%, and that would be considered a partial response. And we're happy in general when patients have a complete or a partial response. So in general, we call those an overall response rate. Anything less than that, we don't consider a response. So for example, if that mass measures roughly the same, we call that stable disease, and in some situations that's acceptable as well. But if the mass grows at least by 30%, or if there are new lesions, then we call that progressive disease. So this is an example of a metric that we use to gauge the effectiveness of our therapies. Now, the other metric that we use to gauge the efficacy of our therapies is how patients do in the long term. And the way we quantify that is with something called survival analysis, or through Kaplan-Meier curves. And so I've shown you an example here of what this looks like. So these are plots of time in the x-axis and some kind of a measure of outcome in the y-axis. So in panel A, we're looking at something called progression-free survival. In other words, how many patients getting a particular treatment are progression-free at any given time. And in panel B, I'm showing you overall survival, which I think is a little bit easier, which is basically what proportion of patients is alive. And so when you begin a treatment, 100% of your patients are progression-free and or alive. And as time goes by, patients are going to progress or die, and those curves are going to begin to drop. So every time the curve drops, that means there's been an event. So we can use that then to see differences in treatments. For example, here I'm showing you a study we did in British Columbia looking at bendamustine and rituximab in blue and R-CHOP in green, and you can see how patients treated with BR have a better progression-free survival and potentially a longer overall survival, and this allows us to compare treatments. So now that we have that out of the way, we'll begin talking about the biology of mantle cell lymphoma. How common is mantle cell lymphoma? It's actually fairly common. If you look at the slide here, I'm showing you the distribution of the most common non-Hodgkin's lymphoma kind of in North America. You can see mantle cell lymphoma is about 6% of non-Hodgkin's lymphoma, so similar to CLL, which I think surprises a lot of people. So crunching some numbers, in British Columbia, we see around 40 to 50 cases per year. Our population is about 5 million. So if you think about the population of Canada, which is about 38 million, we see about 300 to 400 cases in Canada per year. That's a rough estimate, but that just gives you the sense that this is and isn't common. Mantle cell lymphoma is a cancer of the immune system, and this is something a lot of people have a hard time wrapping their heads around. Where is the lymphoma? Where did the lymphoma start? Well, the lymphoma in general begins in the various lymphoid tissues. So I think everybody here is familiar with organs such as lymph nodes, shown here in green, bone marrow, the thymus in younger people. But there are other organs with lymphoid tissues. For example, we have our tonsils and our adenoids, and those have lymphoid tissue as well. And the bowel also has lymphoid tissue because that needs to process all the bugs and all the foreign substances in the food that we eat. So it's very common for lymphomas to present in various parts of the body, above and below the diaphragm, and potentially in extranodal sites like the bone marrow, because of the nature of the system where they came from. And that is the classic example in mantle cell lymphoma, where almost all patients will have stage 4 disease. And remember, stage 4 is something that is made up by humans. We call stage 4 whenever we see involvement of extranodal organs. And in the case of mantle cell lymphoma, bone marrow involvement and bowel involvement is extremely common. And if you look hard enough, you will find involvement of these sites in almost everybody with mantle cell lymphoma. But what is mantle cell lymphoma? I don't know if you've actually stopped for a second and asked yourself, what is mantle? What is the mantle cell? Well, to answer that question, you kind of have to think about the lymph node and where the lymphoma begins. So what I'm showing you here is a slice of one of these lymph nodes that I showed in the previous slide in green. And if you slice that lymph node, you can see that there are different structures that live within that lymph node. Now, the role of lymph nodes is to filter all the different substances that are entering our body and for our immune system to figure out what's foreign, what's not foreign, what requires an immune reaction right now, and what doesn't. And most of that action occurs in these circular structures I'm showing here called germinal centers. And these germinal centers have kind of a shell called the mantle zone. So mantle cell lymphoma begins in the mantle zone of those germinal centers where you have mantle cells. And the job of those mantle cells, which are normal cells, is to participate in that whole process of B cell maturation and B cell developing all the pieces that they need to produce antibodies. For reasons that nobody understands, a genetic error occurs in the process of those B cells developing within the mantle zone, and they develop the characteristics of mantle cell lymphoma. So that's easy to see on a diagram. It's a little less easy for the pathologist to see on a lymph node biopsy. But hopefully you can appreciate in this slide that we have a biopsy of a lymph node, and you can see there are various follicles with their little germinal centers in the middle, and here's the mantle zone. And you can hopefully see that this mantle zone is expanded. It looks abnormal. Normally, the mantle zone should be a nice little shell like an eggshell, but here it's expanded, and that's because there are a number of abnormal B cells that have become cancerous, and that's what leads to mantle cell lymphoma. So let's zoom into this a little bit more. So here you have a B cell that has now become cancerous. This B cell has a mind of its own. It's just going to grow and create additional offspring that are going to live in that same lymph node and in other lymph nodes. Okay, well, let's zoom into what exactly the problem is that happens with mantle cell. And the problem that happens in mantle cell occurs at the DNA level. And at the DNA level, what you see is the expression of a protein called cyclin D1. So almost all mantle cell lymphomas, the genetic hallmark is the overexpression of a protein called cyclin D1. You can see cyclin D1 overexpression in other lymphomas. Sometimes diffuse large B-cell lymphoma will have cyclin D1 overexpression, but by and large, this is a phenomenon exclusively limited to mantle cell lymphoma. And the role of cyclin D1 is the regulation of the cell cycle. So you think about it, every cell in our body is dividing and growing or moving along their cell cycle at some pace. This is why you have to cut your fingernails every so often. This is why you have to get a haircut so often. They're growing at a different pace. And cyclin D1 is one of these proteins that tells that cell how fast to grow or how slow to grow or simply not to grow. And in a lymphoma where you have overexpression of this protein, what it's telling the cell is just keep going. There's no break. It's not that it's stepping on the gas and telling the cell to grow quickly. It's just telling the cell, you keep doing your thing. Just grow. And if you think about a lymphoid cell, they need to grow at a certain pace because they need to respond to antigens at a fairly quick pace. And so some of these lymphomas can grow very quickly because that's the nature of B cells. Other lymphomas might not grow so quickly because those B cells are potentially not that active given where the problem occurred. But this also hints a little bit to what we see in the clinic with mantle cell lymphoma, which is that you treat it, but because it keeps cycling, it comes back at some point. You treat it, but because it keeps cycling, it comes over and over and over. And this is one of the challenges that we have with mantle cell lymphoma, is that we consider it incurable with our current therapies because we haven't been able to overcome this particular phenomenon, as well as a number of others. So once again, this is why mantle cell lymphoma is a tricky cancer. But if you can imagine that this process of cyclin D1 overexpression occurs in every single lymph node and lymphoid organ in our system, that explains, at least in part, why almost all patients with mantle cell lymphoma have advanced stage disease at presentation. So to summarize then, the hallmark of mantle cell lymphoma is the overexpression of cyclin D1. It's a disease of the immune system, almost always advanced stage. And hopefully you can appreciate that cell cycle differs from cell to cell, from person to person. And that means that no two patients with mantle cell lymphoma have the same disease. In fact, mantle cell lymphoma is an extremely heterogeneous disease. And this is something I really like about treating mantle cell lymphoma, is that every person is completely different. So the way to think about the biology of mantle cell lymphoma, kind of at a broader level, is a spectrum. So on one end of the spectrum, you have patients with a mantle cell lymphoma that's extremely indolent. It grows slowly. It grows over a year. Many patients don't even need treatment. And patients can have an excellent survival when they happen to be in this very indolent end of the spectrum. And what's interesting is that many of these patients have something called the leukemic non-nodal variant of mantle cell lymphoma. And what that means is it's leukemic. In other words, you find some amount of mantle cell lymphoma cells floating in the blood, but it's non-nodal. In other words, it doesn't form those large lymph node masses that we see with your typical classic mantle cell lymphoma or other non-Hodgkin's lymphomas. And in general, apart from having some lymphoma cells in the marrow, maybe a little bit of an enlarged spleen, a little bit of bone marrow involvement, usually that's where the story ends for those patients. Now, with the passage of time, they can acquire additional genomic changes and they can progress into the more classic form of mantle cell lymphoma, which is, I think, in the middle, and that's where the majority of the patients we see kind of fall into. But at the very extreme end of the spectrum, you have a very aggressive form of mantle cell lymphoma. And that's when the lymphoma has acquired a number of very aggressive mutations that make it very fast growing, very resistant to treatment, and very difficult to treat. So the classic examples here are something called the blastoid or the pleomorphic variants of mantle cell lymphoma. And those are terms used by the pathologists to describe how aggressive they look under the microscope. These have a poor prognosis and often they don't even respond to treatment. So these are very tricky cancers to treat. So every patient will live somewhere in this spectrum. This is shown in a slightly higher kind of level of complexity, showing here that when you have a B cell in that germinal center, so here's again the germinal center with the mantle zone, and this is where the genetic error happens. Things can happen in the mantle zone in different ways. So for example, one possible error would be a mutation of the immunoglobulin gene, and that's what leads to this leukemic non-nodal variant. On the other hand, if that mutation, if that immunoglobulin gene is not mutated, that cell develops SOX11, and then by developing other mutations can go into these other forms of mantle cell lymphoma. So it's interesting that where and how that genetic error took place and what additional mutations that particular cancer acquires with the passage of time will dictate how a particular person will do. Well, what about group outcomes? Can we get a sense of how people do with mantle cell lymphoma looking at populations? And the answer is yes. So in British Columbia, we're lucky that we have the lymphoid cancer database and we can look at outcomes in all of our patients. And we've been collecting outcomes for almost 40 years. So here's a broad look at almost 1,000 patients treated between 1979 and 2018 at the BC Cancer. You can imagine that treatments have changed over time and diagnosis has changed over time, but just to get a sense of what the outcomes have been historically in British Columbia. Few things come to mind. The first one is that mantle cell lymphoma is a disease of higher male predominance. Nobody really knows why that is, but it's definitely more common in men than in women. The median age in British Columbia is around 67. That's important. That means half of the patients I see with mantle cell lymphoma are generally more fit, potentially younger, and potentially eligible for more intensive therapies, whereas the other 50% cannot handle potentially very intensive therapies, and you have to be a lot more careful around your strategy for those patients. Now, this is the first survival curve of today, and what this is showing you is an overall survival curve plotted over decades. And you can see how this curve drops. What that means is people are dying, and most of these patients are actually dying of mantle cell lymphoma. These curves don't tell you what they die from, they're just telling you that they're dying. But if you think about the idea that half of these patients are under the age of 67, then that means probably the majority of these patients are dying from mantle cell lymphoma. And a figure that I look at a lot is the median survival. So that would be at the 50%. How long does it take for 50% of your patients to die? So you look at this right here. It takes about 4 years. And the other way you could look at it is to say, well, at what point in time, what proportion of patients is alive? So at the 10-year mark, only 21% of patients are alive. Now, I don't know what you are thinking at home, but to me, these numbers don't look very good. This just shows you the biology of mantle cell lymphoma. It just shows you that patients with mantle cell lymphoma don't do as well as potentially patients with aggressive lymphomas like Hodgkin lymphoma or diffuse large B-cell lymphoma. Now, that's the bad part. The good part is we're getting better at treating mantle cell lymphoma. So if you take the same data set and you look at the different eras, because treatments have evolved with the passage of time, and you look at our most recent era, which begins in 2013 when we started bringing in bendamustine and other novel agents such as ibrutinib, and you can see how the red curve looks better than the previous eras when these treatments were not available. Now, that being said, you can see that there is still a lot of room for improvement in our outcomes, but at least it's nice to see we've made some improvement in our therapy, but we definitely have a long way to go. Now, these are group outcomes. These don't answer the question of how will one individual do. So the next thing I do the one thing one should always do when you're trying to assess a particular patient's risk is to look at some of the characteristics that we know are associated with outcomes. And the Mantle Cell Lymphoma International Prognostic Index, or the MIPI, is probably the most widespread prognostic index. I think that's just because it's easy to calculate. And what you do with this is you assign different points for different categories of age, different categories of performance status, categories of lactate dehydrogenase and total white blood cell count. And you can basically add the points depending on whatever those values are. And that allows you to stratify patients into low, intermediate, and high risk. And that in turn allows you to estimate the 5-year probability of being alive. So if you have a low risk, maybe because you're young, you have an excellent performance status, your LDH is low, then the 5-year survival in those patients could be around 83%. But if you have a number of these adverse prognostic factors, then you can see how your 5-year overall survival could be as low as 1 in 3. And this is shown, for example, in these Kaplan-Meier curves or in these survival curves, how low risk in blue patients do much better over time than intermediate or high risk patients. And this has been replicated in a number of data sets around the world. And we use them maybe very commonly because it's a quick and easy way of getting a sense of how a person might do. But notice how the MIPI doesn't really look at many of these biological factors that I explained a moment ago. It doesn't really look at things like mutations. It doesn't look at things like a blastoid or a pleomorphic morphology that we know are also associated with a poor prognosis. And so this is an area of ongoing work. This is work done by my colleague, David Scott, here in Vancouver, looking at an assay that looks at some of these genes in RNA on biopsies from patients with mantle cell lymphoma. So what they've done here is in panel A, they have looked at the expression of a number of genes that make mantle cell lymphoma behave badly. So the idea is the more bad genes that are turned on, the worse the behavior of that mantle cell lymphoma. So when you have a green signal, it means that gene is not present. And when you have a red signal, it means that gene is present. So you can kind of separate out your patients into what we call signatures. And it turns out that this MCL35 assay, where you're looking at the expression of these genes, is also able to separate out your patients into 3 categories of risk, independent of the MIPI, and basically just using biology to help figure this out. Now, whether you should tailor your therapy according to these findings is something that remains largely unknown and largely a research question, but I think this is where the field is moving. So I think that hopefully should give you a good sense of the basic biology of mantle cell lymphoma. But I think it's time to move on to treatment. And when I think of treatment for mantle cell lymphoma or for any indolent lymphoma, one of the things you need to think about is the long-term strategy. So it's not just what am I going to use now, but what am I going to use as the second treatment or the third treatment? Do I burn options by doing one treatment or another? Because the challenge is that we don't think mantle cell lymphoma is curable with our current therapies, and we don't have an infinite line of therapies either. So you have to be careful about how you treat mantle cell lymphoma. But because mantle cell lymphoma is heterogeneous, if you have patients on the more indolent end of the spectrum of mantle cell lymphoma, one could make a case that those patients could be safely observed before they actually need treatment. And that has been a strategy that has been employed worldwide. This is a project I did with a fellow a few years ago where we looked at our cases in BC with proven mantle cell lymphoma, and we tried to look at who are these patients who you can observe. And so what we did is we queried the lymphoma database for patients who needed treatment and patients who were observed. And what this curve shows you in the left is looking at when patients needed treatment if they were observed for at least 3 months. And so the median time to treatment in this experience was basically 3 years. So what that means is that if I'm going to observe 100 patients, at the 3-year mark, I have already had to treat 50 of those, and the other 50 can still go on to be observed. I cannot tell which individual patient I cannot tell the individual patients who will do well and who will do worse, but at least it gives you a sense of how it might play out for a population. But it's interesting. 80% of patients can be observed past the 1-year mark, and there's a small proportion of patients who don't require treatment at least over a decade, and those are those leukemic non-nodal patients. There's an additional interesting piece, which is that when you compare the overall survival of those patients who are initially observed, so I'm showing that in the dotted line, versus the patients who receive early treatment, you can see how those patients who are initially observed have a better survival than the patients who require early treatment. This is just showing you biology. This does not mean that if I decide to sit back and watch every single patient with mantle cell lymphoma, they will live longer. That's not what it means. It just shows you that the patients who we chose for observation did better because they had a better biology to begin with, and they were on that more indolent end of the spectrum. But one way to further interpret this slide is to say, well, at least you don't, doesn't seem like you're harming them by observing them. In other words, we don't think that early treatment necessarily improves overall survival. And there are no data to support that. But at least based on this, we don't think we are harming our patients. Well, that's great, but the reality is that almost everybody will need treatment at one point or another. And I indicated at the beginning of my talk that about half of the patients with mantle cell lymphoma are under the age of 65 or so, and the other half are over the age of 65. And the way we think about mantle cell lymphoma is exactly in those two categories. So you see here how we divide patients into one of three categories: those fit for high dose therapy, and those either fit for conventional dose therapy, or those fit for basically unfit for conventional therapy. And so these are examples of more intensive therapies that we might use. These are examples of regimens that are used around the world. So the theme with a lot of these is that they use a number of drugs. They use regimens like CHOP, DHAP, hyper-CVAD with cytarabine, and in general, they are then followed by additional treatments, including autologous stem cell transplantation. So this is not something that a 75-year-old person can handle, but a fit 55-year-old could very well handle with some toxicity, but should be able to get through these treatments. So that has been kind of the overall paradigm for many years in these kind of younger patients. And the definition changes, but it's something along the lines of, as long as you're under the age of 65 to 70 and in excellent shape, we would consider you eligible for the more intensive therapies. Now, whether or not you choose to go through those is a different story, but at least we present that option to these very fit patients. And again, there are three steps in that process. The first step is to cool down the mantle cell lymphoma with treatment. And here what we do is we use the monoclonal antibody rituximab in combination with a chemotherapy of some kind. And you can use different chemotherapy regimens here. You can use bendamustine, you can use CHOP, you can use DHAP, you can use a number of treatments, and you achieve a response, ideally a complete or a partial response. Once you've had that response, you want to consolidate that response. In other words, you want to really kick that lymphoma as hard as you can and try to bring it down to its least amount of cancer in the body possible. And we do that by giving patients a really high dose of chemotherapy. When you give someone a really high dose of chemotherapy, you can expect a really high incidence of side effects. And one way to get around this is to save people's stem cells before the high dose chemotherapy and to give them back to them right after the chemo so that their bodies can recover. And that's called an autologous stem cell transplantation. That's a transplant from your own stem cells. That's different from an allogeneic stem cell transplant, which means we're giving you somebody else's cell. That's not what we're doing here. Here we're just using your own stem cells to allow your body to get better from the chemotherapy. Now, after all that hard work, you want to keep it that way. And so we then go on to part 3, which is the maintenance phase, where we do just rituximab, so just the immunotherapy every 2 or 3 months for 2 or 3 years to try to keep this going for as long as possible. So it's a very long process. This takes somewhere between 2.5 to 3 years, but that pays off with hopefully a long treatment-free interval for most patients. So the idea then is you want to use rituximab, which harnesses the immune system to recognize and kill B cells. You want to use chemotherapy with drugs that actually get in there and kill the lymphoma cells. And this is an example of the various trials that have been done over the years, looking at various different chemotherapy regimens. And the idea with this slide is to show you that there has been a lot of research done into trying to figure out what is the best chemotherapy regimen for patients with mantle cell lymphoma. So there have been studies of a very complex regimen called hyper-CVAD. There have been a number of studies looking at R-CHOP alternating with DHAP, and there have been some studies looking at bendamustine and rituximab. So how do you choose it's very tricky. It depends on what your local practice is, what your availability of treatments is, how fit your patient is. But the point is that there is no single standard of care. But I'm going to show you one study from all of those to give you a sense of what this looks like. And that is the European Mantle Cell Lymphoma Younger Trial. So this is one of the largest clinical trials ever done in mantle cell lymphoma. This was a large European study of almost 500 patients with mantle cell lymphoma. And they were randomized to receiving 6 cycles of CHOP-R alternating with DHAP-R, followed by a transplant, or CHOP-R on its own, followed by a transplant. And these are the results of that study. So in panel A, in the top, you see the probability of no treatment failure. Same story. At the very beginning of the study, nobody has failed. In other words, the lymphomas haven't come back. And you can see here that the green curve, which is the cytarabine curve, is doing much better than the control curve, which is the R-CHOP curve. And that's true for time to treatment failure. It looks a little bit better for overall survival, but it's not statistically significant. So who knows? But patients are doing better. Now, a few editorial comments here. One, notice how these curves just keep dropping over time. So they're not plateauing, which means that even at the 8, 9, or 10-year mark, patients' lymphomas are still coming back. That's bad, but look at it in a different way. If you look at the median time to treatment failure, that's about 10 years. So that means that 50% of people could go on for a good decade after their treatment without their mantle cell lymphoma coming back. So for those patients, the return for the investment of a lot of toxicity of a 3-year package is actually a really good one. For the other ones, not so much. So that's an example of a regimen that's commonly used in younger patients. And so just to summarize again, it includes 3 components. The other half of our patients are not fit for that type of therapy. And so for those patients, we have to be a little bit gentler and we have to rethink the strategy, but we can still borrow a lot of ideas. And so what we do in those cases is we don't do the consolidation part. We still do induction chemotherapy, so we still combine rituximab with chemotherapy, perhaps not as an intensive, some of the intensive regimens that we use in the younger patients, but we still combine it with chemotherapy. And once you've had a response, then you can think of doing maintenance. So it's a fairly similar idea. And similar to what I showed you for the younger patients, here in the older patients, there are a number of trials that have been done, and you can see how the most common regimens used over the years have been bendamustine rituximab and R-CHOP. So it's just meant to give you a sense of the research that has been done. Now, in Canada and around the world, the most commonly used regimen is bendamustine and rituximab. And that's taken from a large German trial that compared bendamustine and rituximab to R-CHOP, and that's shown in the panel on the left. So this is progression-free survival. So you can see how the BR patients in blue did much better than the R-CHOP patients in orange. But notice how these curves just go down. And even if you look, for example, at the 48, 60-year mark, only 20% of patients are progression free. So this is not curative, but it's definitely giving people some mileage, but not a huge mileage. We looked at this in the BC Cancer Experience. In BC, we've been using bendamustine and rituximab since 2013. We've actually been using maintenance as well in these patients. So you can see how our patients are doing better with BR than when we used to treat them with R-CHOP. So that makes us feel better. But again, even if you look at a median progression-free survival, you're looking at something along the lines of 4 years. So not that different from the 3 years that was seen in the trial. So once again, this shows you that there is a lot of room for improvement. And it also highlights that we need better therapies upfront and at relapse. Now, in Canada, most patients will receive maintenance rituximab after chemotherapy. This is not universal in, like in other parts of the world, but in Canada, most patients will get maintenance. And one of the controversies around maintenance is whether maintenance actually works after bendamustine and rituximab. This was looked at in a small trial called the Maintain trial. This was a European trial in which patients not eligible for transplant, so peripheral blood stem cell transplant, received BR and then were randomized to 2 years of maintenance versus observation. And what this study showed was that there was basically no difference between progression-free survival and overall survival. And the follow-up was reasonable. It was 4.5 years. So this has been a very controversial question in the medical literature, is whether patients should have maintenance after BR or not. Many countries like Australia, for example, don't fund maintenance rituximab after BR because of lack of data showing that it actually works. I think one also needs to balance the cost and the toxicity. And in COVID days, one also needs to balance things around vaccination and safety of vaccination safety, vaccination efficacy, but also outcomes if patients develop COVID. So it's become a conversation, and nobody really knows, and we're awaiting additional data. So, summary of treatment for mantle cell lymphoma up front: 3 phases: induction, consolidation, maintenance in the young patients, induction and potentially maintenance in the older or elderly. I realize these are not the best terms for patients over the age of 65 or 70. Unfortunately, most patients will relapse after their frontline therapy, and you need to think about additional treatments. And here, there are a number of options, and I think there's no single standard of care, and this is changing all the time. But just bird's eye view of what are some of the options that one needs to think about when the mantle cell lymphoma grows again. You could potentially retreat them with a second course of chemotherapy with or without rituximab. There are a number of novel agents with kind of non-chemotherapy mechanisms of action one can look into. Bortezomib has been used broadly over a number of decades. Temsirolimus is no longer used. Every now and then we use lenalidomide, BTK inhibitors. We'll talk about those, PI3K inhibitors, BCL2 inhibitors like venetoclax. I think all of those are options. And then there are some other options like radiotherapy, radioimmunotherapy, and allogeneic stem cell transplant, which is every now and then considered in young patients. And we'll also talk about CAR T-cell therapy. So similar to kind of the laundry list of clinical trials I showed you before, this is just a broad overview of a lot of the research that has been done looking at novel agents. And you can see here the various response rates and the various outcomes and the various sample sizes in these studies. And you can see how the larger studies have involved lenalidomide and ibrutinib. And we'll talk about these. So these are different mechanisms of action. And this is attractive. If you think about the mantle cell lymphoma cell and the treatments that we've used, chemotherapy targets DNA, monoclonal antibodies like rituximab target the surface, in particular CD20. Well, those are just 2 mechanisms of action. But something that people did not really realize for a while is, well, wait a minute, there needs to be a connection between the surface and the nucleus. What's happening here between the surface and the actual DNA? So if you zoom that, so what I'm showing here is, here's the cell membrane. So here's the outside world, and here's the inside of the cell, and here's the nucleus. So this is like a very zoomed picture of what a cell looks like. And so here's the B cell receptor, which sits in the surface of a B cell and gives the B cell its identity. And B cells have a number of other molecules on their surface that also give them their identity. So for example, they have CD20, which is the target of rituximab. So rituximab would bind out here. And they have other molecules shown in there. But point is, whenever an antigen or whenever any of these receptors becomes stimulated, there's a cascade of molecules that gets activated and brings a signal into the nucleus. So that's what this is showing, that depending on which of these proteins is activated, you're going to get a whole bunch of messengers bringing information from the surface into the nucleus of the cell, and the net effect of that will be grow, don't grow, divide, produce some kind of a substance, etc. Okay, well, this is great, because then what this means is this opens up a huge fan of potential targets. And if you can design a drug that is small and able to diffuse through that cell membrane and into the cytoplasm of the cell and attach to any of these guys I'm showing in here, you could potentially have some kind of a pharmacologic effect. So some of you might know where I'm going with this. Here's an example. So there's a molecule very close to the surface called BTK. So you can develop drugs like ibrutinib, acalabrutinib, zanubrutinib that bind to BTK, and they basically shut down the downstream pathways of BTK. So this has really been the breakthrough of mantle cell lymphoma, or one of the breakthroughs of mantle cell lymphoma in the last decade, is this idea that you can use oral therapy, so no IV. Like, this is crazy. This is the first time we have this in lymphoid malignancies, that you can have these targeted drugs that people take on a continuous oral basis, and you avoid many of the issues of chemotherapy. Now, I will say these drugs have issues, these drugs have side effects, these drugs are not risk-free, and you can have some serious consequences from these drugs. But the idea that a different mechanism of action actually works generally safely, I think is amazing. So this was shown in a number of studies, but I think this is the largest one, called the Ray trial. And in this study, 280 patients with relapse or refractory mantle cell lymphoma were randomized to ibrutinib daily until progression or toxicity, or temsirolimus. This is an old drug that was used in Europe for many years and was felt to be the standard of care in Europe. Think about it. Before ibrutinib, all we had was chemotherapy and rituximab. So anything with a different mechanism of action, with any bit of activity, would have been used. And that was certainly our experience before any of these drugs came out, is you basically recycle drugs and you try to get your hands on anything you could, but patients did not do well. So in this study, patients treated with ibrutinib in the red curve had a significantly better progression-free survival than patients treated with temsirolimus. The median progression-free survival in temsirolimus was only 6 months. With ibrutinib, it was only 15 months in this patient population. But you need to remember, these patients had received a whole bunch of treatments in the past. So this was not ibrutinib's second line, which is what most patients with mantle cell lymphoma would get today. This was ibrutinib as the fourth, fifth treatment when all else had failed. So the fact that a 15-month median progression-free survival was seen for these patients is very remarkable. There was no significant improvement in overall survival, but I think that's because the patients who got temsirolimus were then allowed to cross over to ibrutinib. So at the end of the day, everybody gets ibrutinib. So it's really hard to know if it makes people live longer. There have been a number of studies that look like this, and collectively, they bring a number of important lessons. One of them is this idea that responses develop over time. So what this is showing is patients treated with ibrutinib over the course of time. And so here's your overall response rate broken down by complete response in green and partial response in yellow. And what this shows you is that as people take their pills and as their pills work, their lymphomas shrink, and at some point you kind of squeeze out all the shrinkage that you're going to see, and things stabilize, and patients can stay with some degree of visible or measurable disease for many years. It's just not active. So with drugs like BTK inhibitors, we're happy to accept partial responses as a measure of success. We're happy to accept stable disease as a measure of success. If we see a complete response, we are happy. But notice how that will only happen in about 20% of patients. But that's in line with the mechanism of action of the drug. We're not expecting to see complete responses because that's not the way BTK inhibitors work. Another very important lesson is that you should use these treatments early on in people's disease if you want to maximize their mileage. So what I'm showing you here is in blue, patients who received ibrutinib after having had only one previous line of therapy. In other words, ibrutinib was their second line of therapy. Here in yellow or in orange is the patients who received ibrutinib as their third therapy. And the lower line is patients who received ibrutinib as their fourth or beyond line of therapy. So it's nice to see these numbers because what it tells me is, yeah, if you have an effective therapy, you should use it early on in your patient's course. Well, that is very helpful, and it begs an important question, which is, well, maybe we should be using these drugs as the first treatment instead of the second, third, or fourth treatment, and I'll talk about that in a little moment. Now, you're not curing anyone, and patients are still progressing. And the third very important lesson from this study was that patients whose lymphoma progresses on ibrutinib, they acquire a number of resistance mutations that make it very difficult to treat. So here's overall survival from the point of ibrutinib cessation, and you can see how that overall survival is very limited. And that has certainly been our experience in the clinic. When patients have relapsed after a BTK inhibitor, oftentimes their mantle cell lymphomas are difficult to treat. Not always, but for the most part, you get into problems trying to find active agents. So it's a story of it's been great, but I think it's opened additional challenges. But that's okay. The world continues to do research and to investigate what to do with these situations, and there are a number of other options. So where do we go from here? I mentioned bringing BTK inhibitors into the frontline setting, and there are a number of clinical trials looking at this in the young and in the elderly populations. There are other BTK inhibitors coming out, acalabrutinib, zanubrutinib, Luxo 305. We're seeing combos. BTK inhibitors can be combined with other drugs like venetoclax or lenalidomide. They can be combined with chemotherapy. We're starting to ask questions around whether or not transplant is necessary if you have a highly effective frontline therapy. And the question of CAR T cells is also starting to come out. So I think there's a lot of hope. Very quickly, there are other BTK inhibitors beyond ibrutinib. So here what I'm showing is ibrutinib, acalabrutinib, and zanubrutinib. And what these graphs are showing are the different molecules that they block. So you can see how ibrutinib blocks BTK, but as a side effect, it blocks a whole bunch of other of those molecules that I showed you downstream of the cell membrane, and that leads to the toxicity. So with ibrutinib, you see uh, side effects such as hypertension and atrial fibrillation and joint pains, and that's because they inhibit other molecules. Zanubrutinib and acalabrutinib seem to inhibit fewer kinases than ibrutinib, and that might explain why their toxicity profile seems to be a little bit more favorable than ibrutinib, although their toxicity is largely overlapping. This is just a small plug for a study that is being done in Canada. Currently, this is open in BC, PNH, and Quebec, where we're treating patients with R-CHOP and acalabrutinib before transplant and with acalabrutinib and maintenance rituximab after transplant. And this study is going well, and we're seeing some really nice responses, and we are very happy to see more folks for this study. Just a short word on Luxo 305. So Luxo 305 is what we call a next generation BTK inhibitor. This is still a BTK inhibitor, but it works in a different way than ibrutinib, acalabrutinib, or zanubrutinib. And it's a drug to keep an eye on, because even though it's the same mechanism of action, because it is selective and it binds in a different way, I think there might be a benefit. This was evaluated in an ongoing study called the Bruen Trial, and it has various arms. And kind of in the middle here, you can see that they have 61 patients with mantle cell lymphoma treated with this new drug, Luxo 305. And what this shows, this is something called a waterfall plot. And so what this is plotting is the maximum percent change in burden of disease from baseline. So if your cancer grows, you're going to see growth in your disease burden. If your cancer shrinks, you're going to see the cancer, you're going to see these curves go down. And specifically here, the blue bars show patients who had previous BTK inhibitors, and they had very few patients who did not have previous BTK inhibitors. But the point being is that the majority of patients have a response even when they have discontinued their BTK because of progression. So that's interesting because it shows that you can overcome some of the molecular resistance to traditional BTK inhibitors by using a different BTK inhibitor. So this is being studied in the Bruen trial is continuing, and this is being studied in a number of other upcoming trials, and we'll have one in BC at some point. The final treatment I wanted to review is Cartesian therapy. So many of you might be familiar with Cartesian therapy in relapse refractory diffuse large B-cell lymphoma. So in mantle cell lymphoma, there is a similar product called KTEX19. It's Health Canada approved, and I think this is something that will be coming to the clinic at some point soon. So this is the ZUMA-2 trial, which has been presented in the past and has been published. And what this is looking at is creating or engineering T cells that are able to recognize lymphoma cells, and they come supercharged with a number of modifications to their T cell receptor that allows them to recognize and kill these cells very effectively. So that's what this diagram is showing, where it has a component in the surface of the membrane that recognizes, in this case, CD19, which would be on the surface of B cells, and these additional kind of signal components that make it highly active. This was a study of patients with mantle cell lymphoma who had received essentially all active therapies, and in particular, patients who had received rituximab, chemotherapy, and a BTK inhibitor. These were patients in a very difficult situation because of a lack of good therapies. So these patients went on to receive a single treatment with KTE-X19. And on the left, I'm showing you the overall response rate. This is quite impressive. A third of responding patients have a partial response, and the other 2/3 have a complete response. I showed you with the ibrutinib, you see a 20% complete response. Here you're seeing a 67% complete response. Very few patients had a disease progression, and a few had stable disease. So this is definitely very interesting, but you need to remember these are 60 highly selected patients who were chosen for this because it was felt that they could tolerate this treatment. But what I find interesting is the duration of response. So they all get their treatment at time equals 0. And yes, there are patients who experience a progression of their disease, but then the curve kind of flattens out and you don't see that curve dropping anymore. And what's even more interesting, if you look at those patients who had a complete response, the majority of them continue to have a complete response. This is something obviously we need to keep following over time to see whether or not these responses are going to be sustained. Because if you look at the x-axis, the follow-up is still pretty short. So nobody's using the word cure here, but if this treatment is able to achieve long-term disease control, then I think we might see this differently. This is shown also in progression-free and overall survival curves that look very favorable, but I have to highlight two things. One, the follow-up is short. Two, CAR T-cell therapy is not easy. CAR T-cell therapy has a number of side effects, one of them being cytokine release syndrome, where essentially there is an overactivation of the immune system, and that can lead to a number of problems with fevers, abnormal vital signs, confusion, tremor, and many of these patients need treatment in the ICU with steroids, IL-6 inhibitors, and many patients can have some prolonged CRS that takes a while to settle and could leave them with some degree of disability. Similarly, there is a probability of neurologic events. Some patients can have seizures. They can be confused for a while. So I think one needs to be really careful that even though these treatments seem to be effective, you also need to be really careful about who goes for these treatments. And obviously patients need to be very informed of the risks that they need to be willing to assume going into these treatments. There's also the issue of availability and the cost of CAR T-cell therapy. And that's something that we're continuing to work on. Nonetheless, I think it's very interesting. So to conclude, hopefully you can appreciate that mantle cell lymphoma is a heterogeneous disease. In 2021, we still use chemotherapy and rituximab as the frontline standard of care. Of all novel agents, BTK inhibitors have the most favorable outcomes and toxicity profile, and these are really standard of care around the world. What to do upon resistance to BTK inhibitors continues to be a question, but it is an area of active research. And I think that's where CAR T-cell therapy will probably come in for most patients. And I do think CAR T-cell therapy will become part of the algorithm, not for everyone, but definitely for selected patients with relapsed refractory mantle cell lymphoma. So with that, thank you all for listening to me, and I look forward to the discussion in a moment.
Thank you very, very much, Dr. Villa, for your excellent presentation on mantle cell lymphomas. We appreciate your incredible review of this lymphoma subtype, detailing treatment options for patients both in the frontline setting and in the relapsed refractory setting, and also highlighting newer treatment options that are becoming available for Canadians. I would now like to go ahead and direct our audience to attend the breakout session on non-Hodgkin lymphoma to have your questions answered live by a panel of hematologists and oncologists. Thank you very much for your attendance.